With this, as indicated, we're indeed based here in Yokneam. This is now a substantial business. We're employing over 200 people with R&D budget of over $30 million, supporting a business which is well over $1 billion now. It's amazing, you know, just to think about how small it was 15 years ago. Over 150,000 cardiac procedures are performed on an annual basis. I'm going to talk about, and we're doing a lot of things and focus not only on atrial fibrillation, but obviously atrial fibrillation is one of the most important challenges, very substantial prevalence. Some of the patients are asymptomatic, respond to drugs, etc., but they're still at the end of the chain, as you see kind of here below. Over 4 million patients that essentially have no solution. Only 3% are being ablated today, less than 3% of them. And the challenge is how to get more of them treated. Those who are being treated successfully see very, very substantial benefit to quality of life. I'm not going to talk about the all the mechanism of atrial fibrillation. There are people here that know better than me. And again, a lot of approaches have been developed, but eventually the approach is pretty standard. Isolation of pulmonary veins plus additional lines, plus potentially ablating at specific areas that are responsible for the maintenance of atrial fibrillation. Looking at the results, and these are the results of our PMA study that got our catheter approved for treatment of paroxysmal atrial fibrillation in symptomatic patients. So this was approved in the US a few years ago. And these Kaplan-Meier curves look at the ablation arm versus the drug arm. Very nice results, roughly success rates in the 70 to 80% range for paroxysmal atrial fibrillation patients. However, when going and looking at the more complex patients, at persistent and long-standing persistent, the story is not as appealing. This is now here from Mark Josephson's group at Beth Israel. And here we're kind of looking at paroxysmal atrial fibrillation and all the others. And so these are persistent and long-standing persistent. These are the terms that are being used today in the guidelines. And the results here, this is a rather small group, but there are a lot of publications that are all pretty similar. So this is just as an example. This is by itself a rather small study, but the results in the literature are pretty consistent with this. For paroxysmal atrial fibrillation at 1 year, you see the results here in the 70 to 80% range. But when you look at the non-paroxysmal patients, at 1 year, the success rates are in the 50 to 60, and then over time, the success keeps going down. So this is kind of really the challenge, and there are essentially two challenges here. First is the success of non-paroxysmal patients, and the other is durability, to see that this treatment is successful long-term. I'm going to skip this and going to go directly to, so what's next, how we continue from here, and two general hypotheses. One of them is we're not ablating the right locations, or the strategy where we put the lines or where we put the ablations not the right location. The other one is that we're doing it in the right location, but the ablation is not effective. After all, this is not surgery. This is closed chest. You put a catheter. You think you touch. You're not sure you touch. It's not clear how effective ablation is. So these kind of generally are the two issues. On the one hand, maybe we're not ablating the right location. The other one, we're ablating the right location, but we're not doing it effectively. And so one area and one direction of research, and we have quite a few programs on this, is to go back to EP. The procedure that I've shown you is pretty anatomical, is, you know, putting lines. Some doctors are actually doing it without even looking at ECGs, right? You just put the lines, you take an anatomical map. So back to basics, back to EP. Let's look at the signals. Let's analyze the signals. Let's understand the disease. Let's treat where we need to deliver the energy. So that's one direction. We have quite a few programs in this area, but I'm not going to talk about them here. They're a bit early in stage and harder to describe. On the other side of it is to improve the effectiveness of energy delivery. Dr. Bulus talked about his experience with Smart Touch. Since he's already talked about it a bit, I'll skip a few of the slides. And the other one, I'll talk about a program that is early on, trying to assess the lesion as it's being formed. And what you see here in the bottom is a cartoon kind of showing the temperature. It's actually not a cartoon, it's actual results of the temperature profile under an ablation catheter during ablation, and this is obviously dynamic. You see the temperature as it evolves. And so I'm going to talk about these two. SmartTouch, as indicated by Dr. Bullis, is already used clinically. It's CE marked and approved in Japan. Over 20,000 procedures have been done in the first year since it was launched last year, and 350 hospitals already use it on a pretty regular basis. The other concept is the concept of lesion assessment that I'll talk about. So Dr. Bullis showed this catheter. I'll maybe skip this, and there's a video clip that kind of describes this. I hope that the video would work. And
introduces the Rappaport SmartTouch contact force sensing catheter, a new measure of success in complex cardiac ablation. The Rappaport SmartTouch catheter accurately measures contact force and normal by utilizing the vital system electromagnetic location technology. Inside the tip of the Rappaport SmartTouch catheter. A location reference tip is transmitted from a coil in the tip electrode and monitored by location sensing coils, which detect micro movements of the tip in response to contact with cardiac tissue. The tip electrode is mounted on a precision spring, which provides consistent movement in response to contact force, enabling the precise calculation of force in grams. This information is displayed in real time on the Cardiovascular system's graphical user interface. The numeric display of force is shown in grams, while the direction force is also indicated. The force magnitude and direction is also displayed as a vector on the catheter tip icon in the cardiovascular. In addition, the force can be displayed in real time on the force graph. By providing precise contact force data in real time, integrated with the Cardiovascular system display, the Rappaport SmartTouch catheter provides a new measure of success in complex cardiac ablation.
so this is the SmartTouch catheter. There's a lot of reports similar to what Dr. Bullis shared with regards to improvement of results. Obviously, this is still early on in the usage of this product, so no randomized study have been conducted yet, so this is preliminary, but anecdotally, it seems like knowing whether you're in contact, and it's amazing how non-trivial it is, because in many cases you think that you're in contact and you're actually not. You feel the friction, it's the friction of the catheter with the sheath, not the contact with the tissue. So it's amazing, and very, very experienced users have improved their technique and are improving it as we speak based on information. They're getting this force information that in the past was not known. The next concept I'm going to speak about, and this is now early on, we call it internally AccuBlate. And this is trying to take all the pieces of information that could be available in the tip of a catheter. As you understand, this is once developed going to be a very complicated catheter. All this is going to fit into a tip which is 2 millimeters in diameter. So in addition to the contact force, and it's clear that having force information is critical, measuring impedance, and having microelectrodes that would measure both impedance and electrograms. And the idea is you take all these pieces of information, have a model of the tissue, and using the model, take all these pieces of information and simulate the formation of the tissue. This is the tissue temperature profile within a tissue under a catheter. We have done this so far in vivo, both on a thigh muscle model as well as in vivo, in beating heart. And the initial results are very promising. What you see here are actual pictures of the cut, the histological cut. The borders of the ablation are rather clear, and this is what the model has predicted. And when you look at the results of the histology versus what we've modeled, it seems to be very, very consistent, very promising. In addition to that, since we're measuring the temperature at the hottest spot is very important and very critical, because for people that do ablation, know that you can get steam pops. If the temperature there, the pressure gets too high, you get a steam pop, which typically is linked to complications which you would like to avoid. And we have here another graph, again from a series of animals, where we clearly see this is the estimated hotspot temperature. There's a threshold that we put there, and as you see, once you cross the threshold, you start getting steam pops. And so this technology, not only being able to calculate the temperature profile of a lesion, also able to provide an alert before a steam pop occurs. So these are the two technologies I wanted to talk about. One of them is already in pretty wide clinical use, not yet in the US, but we'll probably get to the US within a year. And the other one is still in early concept. Both are, again, addressing the question of how do we improve the generation of lesion and assessing the lesion as it's being formed. Thank you very much for your attention.